like to begin by thanking Dr. Yin-Jun from North Shore University Hospital, as well as Angela Capone, the community relations person, Dr. Charles Fasanya from Catholic Health, Good Samaritan Hospital, University Medical Center, as well as Jason, Board Director, Head of Community Relations, Dr. Victor Politi, American Family Care, Urgent Care Centers, and Roxanne Rose, their Director of Community Relations. Also, I'd like to thank Supervisor Angie Carpenter, I don't have to look at notes for this one, for providing Islip TV. This is great that we're able to kind of broadcast this throughout the town. We'd like to invite Angie up to say a few words.
Thank you very much, Rich, and thank you to everyone for attending. There's nothing as disappointing as planning an event and not having people show up, so it's very kind of you to be here tonight. And I think by the end of the evening, you're going to be very glad that you did come. I want to thank the West Islip Chamber and, quite frankly, all the chambers across the town. I had a conversation just yesterday with a reporter from the Islip Bulletin, and she was asking me, well, what does it mean when the chambers sponsor events? You know, how does it really help the town? And it really, really does, because we just can't do it all. So when the chamber takes something like this on, a healthcare initiative to bring information to the public, provide refreshments, and again, I want to thank Northwell, South Shore University Hospital, of course, Catholic Health, Good Samaritan Hospital, Good Samaritan University Hospital, and of course our good friends at American Family Health Centers. They do a great job at American Family Care, and a special shout out to them during the pandemic. They were our go-to facility. The number of tests that they were able to process for us during that time really was huge. So we want to thank you for your commitment to the community. And without further ado, let us be enlightened. Thank you.
So, well, I can't follow this guy, he's so charming, but I'll try my best. So I'm just going to talk about where we've got to, Catholic Health, in terms of progressing to future better things. The most important thing I can mention is we were recently given a level 1 trauma verification by the American College of Surgeons. That's the highest level of trauma in the nation. There are actually 4 trauma centers verified by the American College of Surgeons, 1, 2, 3, and 4. The 3s and 4s tend to be the smaller ones in regional and sometimes rural areas, though you do have some level 3s, actually even on Long Island here, Brookhaven. But 1 and 2 is where most of the severe traumas go to. So we are currently a level 1 adult trauma center and a level 2 pediatric trauma center, which is a similar level of acuity. So whether it's a car accident in a kid, or a severe fall, or even unfortunately now gun violence as an epidemic, or in adults, really the same type of patients come to both level 1 and 2. There are some slight differences between the two. So as you know, we're building a brand new hospital. I'm sure you drive out there every day. Very expensive these days. That's close to $500 million. And I always try and work out, where does all the money go? Is it gold buried in the basement? We don't know, but it costs that much. A lot of it is technology, new hybrid ORs, which can do both radiology things, operating, bringing a lot of expensive equipment inside the hospital itself, and high-tech stuff. So basically, if you look at what they're building, it's basically a 6-story, 300 square foot modernization. It's going to be obviously new technology in there, new innovative architecture. So it's going to be a state-of-the-art 75-bed emergency department. I know that those of you who have been to Good Sam recently, the ER is our biggest problem because it's fairly old, it's small for our size of visits. We average 90 to 100,000 visits per year, so it's the second busiest ER on Long Island, so it's a squeeze. So this new ER will definitely decompress that with brand new bays. There's going to be a surgical pavilion with 16 new high-tech operating rooms and adjacent pre- and post-care for families to come. There'll also be special hybrid ORs. Those hybrid ORs are very expensive. Even a lot of level 1 trauma centers in America can't afford them. They're just too expensive. And they can alternate between vascular, interventional radiology, and surgery. There's also going to be some new private rooms as well, dedicated floor, single rooms, and then some other future space as we'll plan in the future what we're going to use that space for. So that's very exciting for us. Going back to trauma, if you look at trauma centers versus the ER just generally, what's the difference? So both care for accidents, emergencies, minor to severe, but not all hospitals are designated as a trauma center. So basically trauma care teams treat patients that have critical injuries which are life-threatening to the life or limb. Those severely injured patients require multidisciplinary comprehensive medical services. Most trauma centers have specially trained trauma surgeons, like myself, who are general surgeons primarily, but we also trained in ICU and trauma as well. There's certain criteria that you need. Trauma units have the resources and expertise, so that's just from a general level. Going a little bit more specifically, a level 1 is the highest level of trauma, as I mentioned, so the most severely injured patients. So we're talking about falls from heights as well as standing in elderly patients who may have hip fractures, etc. Gun violence, as we mentioned, or penetrating trauma, motor vehicle accidents, motorcycles, car accidents. Basically, its role is to perform leadership in injury prevention education, continuing education for the emergency medical services, the EMS pre-hospital care, and also as a nub for organizing teaching and research. So it's kind of a regional tertiary center, basically. The resources and funding are expensive. In New York, it costs about $3 million, the gap analysis, to get to a level 1. Level 2 are similar in the sense that they have a similar level of acuity. The only difference in level 2s really is that level 1s have a bit more resources, can do a few more things, and also there's no requirement for research in level 2, whereas there is in level 1. And level 3, the primary difference is the time response. So level 1 and 2, you need to respond to a car accident, for instance, within 15 minutes, which you can see is a short time. If you're at home, you get out of bed, wash your teeth, get out of your pajamas, drive to the hospital, it's too late. And that's rigorously monitored. For instance, 80% of the time in a 3-year period, you need to be there within 15 minutes. So if you just think about, that's 24/7, 365. You don't have many areas where you can really be outside that window. And if you don't do that, that's called a type 1 deficiency, it's an automatic failure. So they walk in, they check that, it's not that, you failed immediately, they walk out. So you can see, to get there within 15 minutes, you really have to be in the hospital. And actually, our on-call rooms are right next to the trauma bay. So at 3 a.m. in the morning, we literally wake up, and you can walk or run there in 15 minutes. But it's not much time, especially when you've just got up at 5 a.m. in the morning or 3 a.m. in the morning. So that's an important component. Also for level 2, there's a 15-minute response time. Other specialists as well have response time, like radiologists, neurosurgeons, orthopedics. All of that is monitored, and we really pay a lot of attention to that. Level 3, they have a 30-minute response time. That's the biggest difference in level 3. So you can see the trauma surgeons don't need to be in-house, because if you live close by, you can get there in 30 minutes. Although many level 3, many of the surgeons do stay in-house just because it's a bit difficult to get. The other difference is a few other things which we can get to a little bit. So the American College of Surgeons has a committee on trauma. They verify trauma centers. They have something called the Verification Review Committee. The standards, the books, they always change colors. When I first got into trauma verification like 15 years ago, it was a green book, then it was an orange book, now onto the gray book. They really keep on changing it and trying to simplify it, make it a bit easier. You can have a consultative and a verification visit. We didn't do a consultative visit at Good Sam because we've been verified as level 2 for many years in a row, so we didn't need the consultative visit to go to a 1, because clinically they're similar, it's more about the research. But a lot of centers who are not sure, they get a consultative visit where the American College of Surgeons come, they look at you and they say, you're not quite there, you need more resources, come back in 3 years, or they may say you're close to it, do this and that. And you pay for both of these. It costs about For adults, I think it's between 35 and 40,000, maybe even more now. Pediatrics is a similar cost, so it's quite expensive as well. And pediatrics is separate from adult. So you pay for that visit to make sure that you don't waste your time getting a visit and you're not ready. And then the verification visits to make sure you're ready. You have a 3-year verification cycle. So once you're verified, the New York Department of Health then verifies you, but they listen to the American College of Surgeons. They really follow them quite closely. So some of the criteria is the number of patients. You need over 1,200 patients per year. We tend to average about 1,800. Or you can have 240 trauma patients per year, but they have to have a high injury severity score. That means that they're severe accidents. So like car accidents, gunshots, where multiple systems are injured. We use the National Trauma Data Inclusion Criteria to really select these patients, and you need about 10 trauma-related research articles in the 3-year cycle. You also need some other research activity like residence, fellows, and visiting professorships. So at Good Sam, you can see 2,100 injured patients each year on average in the ED, and about 1,700 of those are admitted each year. So we fulfill the number criteria pretty easily. Other requirements is my job, which is a trauma surgical critical care surgeon. So we're double board certified in general surgery and critical care, ICU. And many of us, in fact, during the COVID pandemic, we actually did a lot of ICU with COVID patients. I actually worked in California under the state emergency for 3 months in the COVID ICUs during the big surges. So we cover the surgical ICU. You need to have a surgical ICU as a level 1. You also need a director who's specifically trained in surgical critical care. The response time, as I said, is 15 minutes. 30 minutes is the next level, that response time for ones who are not quite as badly injured as the other group, although the two groups can mix between each other. So for instance, the 30 minutes response patient, I've had some of those who are more severely injured than the 15-minute response patients, because you don't really know all the time when the EMS call the patients in how bad they will be when they get there. Then you need a trauma response team, which is a team of people like anesthesia, respiratory therapists, trauma surgeons, residents, etc. And as I said, a trauma surgeon in the hospital 24 hours a day, 365. And many of us also do emergency general surgery as well. You need a bunch of subspecialists, neurosurgeons, plastic surgeons. The orthopedic surgeons we use in trauma, specially trained in trauma, so they're fellowship trained, and they can take care of complex pelvic fractures and complex fractures in adults and children. All those other specialists you can see, you need all of that. For instance, let's say the patient needs dialysis, you need a nephrologist, you need rehab, extensive rehab for all these trauma patients. And all of these are time-oriented, so everything we monitor with performance improvement, like radiology, like if we do a CAT scan, we need the report within 30 minutes, so everything is timed in trauma. You need an OR that's staffed and available for emergencies 24 hours a day, 7 days a week. Interventional radiology, they help us a lot, where they can go in with tiny catheters and shoot little coils to stop bleeding. You need rehab, as I mentioned. Also with level 1s, you have to have a surgical residency. At the moment, Stony Brook residents rotate with us, the senior residents, but we're starting our own residency this year as well. They'll actually come physically next year. We're also getting a surgical critical care fellowship, which is a recommendation from the American College of Surgeons, where after they finish their residency, we train them in critical care ICU as well for a year. And many of us have affiliations at the NYIT-COM, which is the New York Institute of Technology College of Medicine. So they want academic affiliations with medical schools. The support, as you can see, there's a trauma medical director. We have a separate adult one and a separate pediatric one who's a pediatric surgeon. We have our trauma program manager, separate adult and pediatric, because we're the only pediatric trauma center on South Shore. So we were combined, as I mentioned before. You need an injury prevention coordinator who goes into the community, helps with things like preventing falls so you don't get hip fractures, kids, safety, gun safety, all those kind of things. Seatbelt prevention, teenagers distracted driving, those kind of things. Then we have, because we need research, we have our own separate research manager, scientist, statistician, performance coordinators, analysts. You can see it's a whole bunch of people, registers who record all our data, and advanced practice providers like PAs and nurse practitioners. Other requirements are disaster and emergency planning, registry and national benchmarking. We compare ourselves against all the other trauma centers in America, and we break down all the areas where we could improve. Regional and state trauma advisory committees. We're involved in Albany. We go up there to the State Trauma Advisory Committee, and regionally here on Long Island. We have a lot of multidisciplinary performance improvement and patient safety initiatives. Every month we review all our cases and we see where we can improve. A lot of education, as you can see. Courses on ATLS, which is a famous course, a flagship course by the American College of Surgeons, where we teach trauma surgeons and ER doctors how to take care of trauma patients. That course has been going on for over 40 years now, and we teach those courses. Stop the Bleed courses, you might have seen them in the community. They go to schools, etc., and different places. For instance, God forbid, there's a open shooter, or a lot of crazy people out there now, right? Someone starts shooting. How do you get immediate control of bleeding at the scene? Fall prevention classes, as I mentioned. Level 2 pediatric trauma is similar, except there's a lot of pediatric people. So the pediatric ER people, the pediatric intensive care unit, the pediatric subspecialists, whether it's ICU, orthopedic surgeons, neurosurgeons, anesthesiologists. These are specially trained people for kids. Then continuing education for the pediatric team, and the injury prevention for schools. And that's it. Any questions? I know it's a lot to take in, but I tried to summarize everything in a nutshell.
I have one question. So we at Good Sam, you're the only trauma level 1 and 2 trauma prevention centers on the South Shore, or are there other?
We're the only pediatric trauma center on the South Shore.
Okay.
But
Actually, all of Long Island.
All of Long Island?
Yeah,
Oh.
pediatric trauma center on the South Shore.
Yeah, exactly. Stony Brook do have a pediatric trauma center, but they're on the North Shore.
Right.
They're level 1s. Stony Brook are level 1. We're a level 1. I'm not sure about South Shore, but
We're level 2.
There too.
you're 2, right?
Going for a level 1 this year.
Exactly.
Yeah. So you're a busy place then?
We're pretty busy.
Good to know.
How is it getting staff? This is pretty intense.
Yeah, it's pretty intense. It takes a lot of commitment, a lot of money, a lot of investment from the administration, the system. Even if you look at the US World Health reports, which look at all the top hospitals in America, it's a kind of stamp of honor to be a level 1 trauma center. Even places like Harvard, Vanderbilt, Columbia, Cornell, a lot of them like to be level 1 trauma centers because it upgrades the whole hospital system. So it's something definitely valued, and something that a lot of tertiary centers, big hospital academic centers with medical schools, they like to be level 1 trauma centers. In New York, it's a little bit different. You see places like Columbia and Mount Sinai that could be level 1 trauma centers, but they don't have the volume because they're in Manhattan. There's not enough trauma in places like that, so they don't need to be trauma centers, and they don't. But Cornell is a burn and a trauma center as well. But occasionally you do see some cities with big centers that are not trauma centers. But if you go around the rest of America, most big academic and tertiary large hospitals are level 1 trauma centers. Yeah.
We're blessed to have 2 really great hospitals within a stone's throw of each other. Are there some specialties other than level 1 that Good Sam has versus Northwell? Are there any services or specialties that Northwell offers that Good Sam doesn't have?
I would say that they're pretty similar. Most level, now we're only talking about trauma, I don't know about other
I'm
specialties.
talking in general.
Oh, in general? I can't answer in general.
Non-professional.
I just don't know enough. I've only
Place to
been
Okay.
with this hostel for 1 year, so I don't know enough about the region. But I would say that most tertiary hospital centers at this level have similar capacity and do similar things.
I think there's certain pediatric specialties that we have that Northwell South Shore University Hospital doesn't have. I'm not sure if on the reverse.
I think we're supported by Cohen's as for our pediatric
Right.
arm. And we recently have, not sure, it's the issue of being in our own specialties.
They're both very new.
Yes, we're
Yeah.
both very new,
Yeah.
but I know recently we got joint commission accreditation for several of our programs as well.
Yeah.
And again, you guys I'm sure have joint commission.
Yeah, they have Cohen's children, because I used to actually work for Northwell for almost 9 years. I worked for Staten Island University Hospital, so I know the Northwell system very well. And we also, even though we're a pediatric trauma center in Staten Island, we used to transfer a lot of patients to Cohen's children. So they're more regionalized, they're children's, but we have our own pediatric trauma center at Good Sam.
So Good Samaritan also is a comprehensive stroke center by both the Department of Health and Joint Commission. We perform endovascular stroke procedures, which they do too. Because of our volume and other research aspects of it also, we were able to go for those designations to make it the highest level stroke designation. So that's one of our premier services. We both have open heart surgery at our facilities, and we're both supported by other, facilities within our system. So.
Yeah, and they do education. I think they have residents rotate there through their system. We are getting our own residency and fellowship now as well.
We have a general surgery residency
Yeah.
of our own. So, yeah.
What do you have available for lower back disc compression treatment?
Well, we have a big spine unit. It's huge, actually. We do a lot of spinal
We do a
surgery.
lot of neurosurgery and spinal surgery.
We're accredited by JACO. We just recently
Yeah.
had our JACO accreditation for spine surgery. But we have a lot of neurosurgeons who do a lot of spine surgery.
What's your first step when you don't do that?
My talk is going to.
That's gonna be
Okay, you're
We're-
gonna,
I'm talking about-
As a community,
But you
we're
can-
very fortunate to have two great medical institutions right here. And what's even better is that they do get along. We see a little bit of, give and take, but for the
Healthy
most part,
competition.
the partnership is awesome. And with that, I'd like to invite up Dr. Jun.
Yes.
Jin?
Oh, wait, we need to switch it up then. Is that it? Oh, you have the clicker. Let's steal the clicker. Thank you. Alrighty. Well, thank you everyone for attending. Thank you for the town, to the town of West Islip and the chamber for having me. My name's Yike Jin. I'm relatively new here. I am a neurosurgeon that is fellowship trained in complex spine, and I serve as the director of complex spine for South Shore University Hospital, which is just down the street. So, I want to talk today about growing of tertiary care neurosurgery at South Shore. So, South Shore, for people who've been in the area for a long time, I'm told has grown quite a lot, and then certainly we grow every day. But we've grown very much from what we've been even 3 years ago. And then neurosurgery as a department and spine care as a department, as an overall subspecialty, has grown immensely also in the last 3 years, and certainly since I've gotten here as well. So, to start at the beginning, there's the Southside's first days opened in 1911, just a very quick, history. 21-bed hospital, it's called Babylon Hospital back in the day. 2 years afterwards, it was named Southside Hospital, which is the name that stuck until very recently. Back then, didn't have the greatest fiscal numbers, revenue of $138.51 of the debt of about $3,000. Skipping a couple of years. Skipping a couple of years, obviously we grew as history grew. So, Southside Hospital relocated to where it is now, where South Shore is now, 6 miles east of the Bay Shore's main street. And certainly, we weathered a lot of the events that, of that time. And ultimately, in 1990, Northwell and North Shore, LIJ healthcare system at the time, came in and sponsored and really sort of helped out Southside Hospital at the time, but by taking over and contributing in 1996, and then ultimately opening a new cath lab in 1999, and ultimately taking over ownership in 2005. And now, one of the first premier programs that we had at South Shore was basically PCI and cardiac care and cardiac intervention. So, we continue to grow. So, in the past, the present, and really the future. So, we are also building a new pavilion. And this is what it would look like. Basically, it's also meant to have brand new ORs. It's probably about double the size of our OR capabilities. We have brand new hybrid rooms. In a more recent future, we're going to actually have 2 new rooms in the bracket pavilion. One will be a hybrid room that allows for both interventional cardiology as well as cerebral vascular neurosurgery procedures to be done. But this, again, the pavilion will come up and ultimately be the future South Shore University Hospital Intimate Family Campus. That, again, in that room will also serve a lot of ORs that are designated for spine. A lot of strategic investments. I won't go through all of them, but the ones that are particularly important to me. Obviously the emergency department we completely revamped. It's now the Bolson Family Emergency Department, as well as the Linda and John Bolson Neuroscience Center, state-of-the-art neuro ICU that specifically looks at taking care of patients who have had neurosurgery or have a neurological issue. So this is your strokes, this is your brain bleeds, this is your large spine surgery needs, postoperative needs, all in that brand new 8-bed neuro ICU. And so, our team has actually grown. So, I'm the newest addition to that team, but, our team currently, as it stands for neurosurgery, is 4 surgeons strong. We have Dr. David Chaliff, who is our current chair. He does cerebral vascular and neuro-oncology, so this is your brain tumors, this is your aneurysm clippings, this is your AVM, arteriovenous malformations, bleeding in the head. Dr. Thomas does some brain tumors as well as overall spine, so he's sort of our generalist. Dr. Georgios Kleronomos does skull base and neuro-oncology, so these are these very tough tumors right at the base of the skull, pituitary tumors and such, and also does open cerebral vascular, so he also clips aneurysms and does that sort. And I specialize in complex spine and also do neuro-oncology with brain tumors and spine tumors as well. And just like South Shore is growing, we're also going to grow. And so, Dr. Chaliff will be leaving us, and we really do thank him for all the work he's done to grow our program. But we'll be adding 2 new recruits. Dr. Ann Liu is actually was 1 year behind me in residency. She's a great addition. She also does complex spine and neuro-oncology. And then Dr. Kevin Shaw is a dual-trained cerebral vascular surgeon, so it means that he can do both the endovascular, the minimally invasive, through the small tubes in the groin all the way up to the head, putting little coils in to block off aneurysms, block off blood supply to different brain tumors, as well as the large traditional brain surgery where you open the brain and you go in and you clip aneurysms and such. So all great additions. Our program is growing significantly. So what is spine care at South Shore? So what does that really mean? And at the end of the day, spine care at South Shore is very much a philosophy that we have. So spinal disease is multifactorial. So anyone who tells you that it's one thing that's causing your back pain is wrong by definition. There's always a combination of things: psychosocial factors, work-related factors. If you work in construction, that's going to be different than if you have a desk job. Right? Autoimmune disease, so some people have diseases of the spine, of the bone, that alters bone metabolism, alters the way that your spine adapts to trauma and adapts to inflammation. Musculoskeletal disease, the most common, this is when you lifted something or you did something you probably shouldn't have done, and then your back gives out and you're miserable for 2 weeks and you get better. That's the most common. So that happens to I think all of us on any given time in any given year. And demographics, unfortunately, age and gender can, play against us. We can ultimately have things that are age-related that just are due to what I tell patients is normal wear and tear, living a long, full life. Sometimes will lead to some spinal disease. So because it is multifactorial, the treatment is multidisciplinary. And I think one of the great things that we have the opportunity to do is collaborate with some of the professionals in our community. So certainly not everyone that we collaborate with is Northwell, but certainly people that have been in the community a long time. Physical therapists, pain management specialists that have a great reputation and patients love. And we love working with them. So psychiatry, clinical psychology, physiatry, physical and occupational therapy, pain management, medical treatment and management. So sometimes purely just doing things such as optimizing your diet, increasing your exercise will help spine disease and help spine pain. Chiropractic, meditation, and alternative medicine. And I put spinal surgery last there because it truly is in our philosophy that spine surgery is a last resort. It should not be a first resort for anybody unless, we'll talk about this, specific emergencies that it is something that you have to do spine surgery for. But for the vast majority, spine surgery is last. And so I think that's important to understand as a philosophy. So let's talk about back pain, because back pain is what we're here to talk about. So, starting with back pain, if you just have back pain, that's what we call axial back pain. So basically all that means is you have pain in your back. And usually it's due to a combination of joint or facet hypertrophy. That's a fancy way of saying that your joints, because as you wear and tear them through normal everyday life, your joints will develop an injury, and your body treats that by building up more and more bone, more and more cartilage, and eventually that can cause pain because it's an inflammatory response. The body's responding to sort of the everyday wear and tear. Ligamentous hypertrophy. So your ligaments are the same. So as you stress your ligaments, depending on what you do, depending on how active you are, your ligaments will also develop more scar tissue and develop more mass, and that can cause pressure on certain nerves that can cause you to have back pain. In rare situations, but certainly situations we see very commonly as surgeons, instability. So some people have had a fracture or have even wear and tear that leads their bones to move in abnormal ways. So your spine you think of as as a tower, if you will. Now if you imagine sort of the bricks in the tower abnormally moving, you can imagine how that might cause some pain and cause some instability. And then muscular strain, again, is most common. And again, people oftentimes will be relatively sedentary and then do something, like lift a 50-pound bag over their head. So that oftentimes can happen as well, and that causes axial back pain. You can have axial back pain and one of these. So you can have what's called radiculopathy, which is a term that I think people may be familiar with. This is your shooting pain. This is your sciatica. This is your pain that goes down the leg. So this is usually often caused by disc herniations, as we mentioned before. Disc pops out. Your discs are normally these your little shock absorbers, if you will, between the bones. Sometimes through wear and tear or a certain activity pops out. It can actually cause compression on a nerve root, and that's what causes that pain. The nerve is being irritated. Synovial cysts. So this is sometimes what happens when, getting back to joint and facet hypertrophy, this is what happens when your joints, again, as part of an inflammatory response, respond to your overactivity and form little cysts. And what those can do is, same as the discs, they can push on the nerve roots and then cause things like weakness, numbness, and shooting pain. And then just in general, foraminal stenosis. So this is where the nerves are pinched as they come out through a combination of ligamentous and facet hypertrophy. So again, this wear and tear leading to excess tissue being deposited down. And then we have myelopathy, which hopefully fewer people have heard of. This is more of an emergency in terms of things that we need to take care of quickly, and oftentimes take care of from a surgical standpoint. So this is where you get clumsiness or weakness, and so myelopathy in the neck can lead to things like dropping things all the time, having trouble buttoning buttons, having trouble putting on jewelry, having trouble combing your hair. Clumsiness or weakness in the legs. These are people that walk around and they seem like they're always tripping and falling. So people who, oftentimes family members will say, you walk out like you're drunk all the time, but they're not. And so this is a sign of spinal cord compression, which is very serious. And certainly it's one of those things once it's started, especially if it's from a wear and tear standpoint, unfortunately it just tends to get worse. So the goal from a surgical standpoint is to identify these patients first so that we can go ahead and stop the progression of the disease and prevent them from getting worse from a neurological standpoint. So I want to emphasize again, non-surgical options are always first line, except, and so these are the things I was talking about before. So sometimes patients say, okay, I've had shooting pain on my leg, Dr. Jin, you said go to physical therapy, go to pain management. It's now been 3 months, and I still have really, really bad pain, and I can't do the things I want to do, and they have a large disc. And at that point I say, okay, fine. At that point you've tried, and unfortunately you fall in the category of people who don't respond to non-surgical therapy. Then we can go ahead and do a surgical management, hopefully a small surgical treatment to treat your disease. And then there's the surgical emergencies. So these are, as I mentioned before, cord compression, neurological compromise. So this is stuff where, has anyone ever had someone who's had a dropped foot, where basically they have so much pain that they can't lift their foot off the ground. And when they walk, you'll hear that they'll slap their foot down. That's a sign that the nerve root has gotten pinched so badly and for so long that it's starting to develop motor deficits. And once you have motor deficits, that's usually a sign that we should probably intervene surgically. Bowel bladder dysfunction, also a very severe thing. Bowel bladder dysfunction, sudden onset, that's a surgical emergency. So if you have that, go to the emergency room. And there's a chance that you don't have something, and hopefully that's the case, and hopefully this is just something else going on. But every now and then we will get patients that come in, all of a sudden they were fine yesterday, today lost control of their bowel or bladder, and now need emergent surgery. So This is sort of a gross oversimplification, but I think it makes sense. So I think, if you think about the overall things, surgical things that we do for back pain and just associated symptoms, they fall into sort of these three categories. So first one is a discectomy, okay, and so this is basically oftentimes when you have a disc that's fallen out of place, that's basically herniated or pushed out of place, and it usually pushes on a nerve root, causing that nerve root to shooting pain down your leg or down your arm. And so a discectomy is oftentimes a minimally invasive procedure where you can come down through oftentimes an incision about an inch or smaller, drop a tube down or drop a small retractor down, shave off a little bit of bone and basically reach right next to the nerve and pluck out the piece of disc that's popped out that's pushing on the nerve, completely loosen the nerve up, and your pain goes away. So, I've had patients in the right patients that you identified, with the disc herniation, these patients can come into surgery in the morning. I usually keep them overnight just in case they have any pain, that they need to be addressed, and then leave tomorrow morning and their leg pain is better. Now, obviously now they have a little bit of back pain from the surgery, and I can't guarantee no pain from surgery, but yeah, so these patients can often do very well. Decompression, so this is sort of a larger, form of a discectomy, if you will. So sometimes you can have through a combination of either disc herniation or joint disease or some other pathology, ligamentous hypertrophy or whatnot I mentioned before, where your nerve roots are being pinched, but they're being pinched in multiple areas. You can't just take out a small disc herniation and unpinch the roots and unpinch the nerves. So in those cases, you come into the back and you take basically the bone or the lamina off the back, and it opens up the space for the nerve roots and for the nervous going through as well as the nerve roots traversing across. And that can oftentimes be very helpful for patients who have very severe stenosis or very severe pinching. And then finally, decompression and fusion. So, this is one of those surgeries that we only really reserve for situations where maybe there's abnormal motion. So patients have slip, and you can see on X-rays when they lean forward they slip, and then when they lean back they fall back into place. And these patients will actually sometimes will tell you, the pain is really bad when I walk, pain is really bad when I stand. I lie down and get comfortable, pain goes away. And so that's one of the signs that you have dynamic instability, or rather a slippage that's going on. So the way you stop the pain is you stop the abnormal motion. So oftentimes what we'll have to do is we'll then put screws and rods in, and basically that stabilizes the two slipping bones, and that can help take away and relieve that pain. Okay. So one of the great things that we have at Northwell, and only recently when I came, is we actually recently acquired computer-assisted navigation, so spinal navigation. Okay, so this is exactly kind of what it sounds like. It's GPS for the spine surgeon, right? But what's nice is that we can go ahead and we have an O-arm, which is basically a way to get an intra-op CT, if you will. So patients on the table, we wheel it in, the O-arm opens, closes, and gets an intra-op spin on a CT. And then basically using that, we can tell where on an MRI or where on a CT scan we are when we point to something on a patient. So basic principles of intraoperative navigation. So registration, so this is the idea you place a patient marker on the patient, you get an intraoperative CT scan. You confirm landmarks. So basically you have, intraoperatively you have this smart robotic, camera lens that then looks at the specific instrument you're using and where you're pointing, and it'll tell you based on that where in the CAT scan you're pointing. So you can see exactly, you don't need to see exactly how deep you are there. It'll tell you exactly where you are. So confirming landmarks. So this is just, as with all technology, you got to make sure that you're tech supporting yourself. So make sure that when you're touching bone, it says you're touching bone. So it's simple stuff, but oftentimes very important. And then you have, calibration of your navigated instruments. So, these balls you can put on basically any instrument that we use in the spine. I'd say probably 95% of the instruments we use in the spine. And what happens is then, again, using the eyes, it can register these balls, register what you can put in, what kind of instrument you're using. And again, it can help you do things that normally were done either with a lot of radiation, constant X-rays throughout the OR, putting instrumentation in, or by what we call freehand, which is basically by anatomic landmarks. You're doing it based on what you see in the bone. But as you can see here, one of the benefits of this is that you can, in real time, tell exactly where you are. So for example, oftentimes when we do a fusion surgery, we have to put screws through what's called the pedicle, which is this sort of bony channel there, right? And so it's oftentimes flanked by nerve roots come out here, nerve roots come out here, and there's nerves here. So, as you can imagine, it's something that, obviously takes a long time for us to train to do this safely, but this helps us immensely, right? So we can put drills, taps, screws, whatnot, all through this navigated system, and allows us to do things like do surgery without really cutting the skin completely open. So we'll do a surgery where previously we had a large incision and we opened everything up, we could see all the bone. Now we do small stab incisions where we need to put the screws in, and we go off this. And this is very accurate. So, just some cases, just to illustrate this type of stuff that we've been doing here. So this is a gentleman actually fairly young, said he was basically in the gym, lifting some weights, doing some sort of activity he wasn't supposed to be doing, and felt a pop. And all of a sudden, back pain, shooting pain down the leg. Really bad shooting pain down the leg. And basically shooting pain down the leg in a distribution where basically it would go down to the back of the leg, down to the bottom of the foot, which we usually call, in this case, S1 distribution. So basically each of these nerves has a specific distribution. And so, of course, we get an MRI, you can see, this is sort of what we call a sagittal view, where it's cutting down the middle. The patient's looking here, this is the back, right? These are the individual bones in the back, and these ovals are the individual discs. You can see this disc kind of popped out a little bit, right? And this is an axial, so this is where you just cut you across like this. These little dots are the individual nerve roots, and you can see there's a nerve root exiting here. You can see here, the exiting nerve root here is completely squashed by that piece of disc, right? And so this guy, I sent him to get physical therapy, pain management. He was a young guy, I said let's try to avoid surgery. Unfortunately, he didn't fall in that category that gets better. So we ended up doing a small microdiscectomy, where basically we came down with a retractor, like this shows, and basically took out that piece of disc fragment. You can see this is the instrument there that were used, and it corresponds to the area where that disc came out. He did very well. Luckily, he stayed the night. Next morning, no leg pain, went home. So some cases, really do stretch the ability of us to use navigation. So this spondylolisthesis is basically, spondylolisthesis is a fancy term, basically means that your bone slipped. And you can see here, this bone is slipped forward on that bone, right? And I didn't include it, but you can see that if you move the patient, if the patient take an X-ray, bending backwards and forwards, there's motion between those two. Tremendous back pain. She, I think, was bending over to fix a rug, and then all of a sudden, tremendous back pain, couldn't walk. So ultimately, what you usually try to do is you try to put in screws through the pedicles, like as I mentioned before, and then basically use the screws. You can oftentimes cement the top of the screws to try to pull everything back. But here's the issue. Her specific anatomy, normally the pedicle is this channel, right, from here to here. See how that's channel super small. So very difficult to do from a freehand perspective, very difficult to do without navigation, very difficult to do without advanced imaging. But with advanced imaging, very straightforward. We were able to sort of thread the needle there, put the screw in, and then she's stabilized. And she actually was able to, now she ultimately needed a little bit of rehab, but I saw her, I think, 6 months afterwards, she was walking around. So last but not least, we are also recently, as of April 2023, Advanced Spine Surgery certified by the Joint Commission. So this is the highest level of spine surgery designation. We are the only hospital in Suffolk County with advanced spine surgery designation, and we're actually one of only 4 in New York State. The other 3 being in Nassau. But basically, this means that we've demonstrated that we're a leader in sort of monitoring and trying to minimize surgical site infections. So they combine, they check the number of surgical site infections, they delve into deeply, the root cause analysis for each of these infections. Preventing new neurological deficits. So certainly, when you go in for surgery, you shouldn't get worse. And so, trying to prevent any chance that might happen. Preventing unplanned returns to the operating room. So these are things like you have a seroma, which basically means that you have a fluid pocket that's in the area. You have a hematoma. You have an infection. All those things we want to minimize, and we track very rigorously. And patient-reported outcomes. So we ultimately care less about what the surgeon thinks, how well the surgeon thinks they did, but more about how the patient's doing, right? So we call, and we have a nurse navigator that actually will call, and I think at times people are like, oh man, I'm doing another survey online or on the phone. But we'll ask at 6 months, are you better? If you had a choice, would you go back and do surgery again? And so we actually grade ourselves on that. So the more patients say, hey, I'm doing well, I'm back to doing what I would love to do, I would totally do the surgery again if asked again, is how we grade it. Ultimately, I think that's really ultimately the goal that we need to achieve. Not if the screws look good, not if the surgery went well, but rather how do patients do 6 months, 1 year out. And so, I'll end it there, but I think one of the things that we're really trying to do, our vision really is to provide comprehensive spine care. So what that means is basically this. I've been on the other end. I've been on the side of, I have a new kid, we, take him to a pediatrician. It takes a long time to get all these things set up. Like, we had a dermatology appointment. Did you know we only have one pediatric dermatologist in Northwell? I think there's 2 in the Catholic system, I think. But it's very small. Incredibly difficult to get an appointment. Our goal is that you come in and we help you set up your imaging. You get your imaging appointment set up. We get your physical therapy set up. It's a one-stop shop where we're, ultimately the vast majority of people don't need surgery. And that's a good thing. And so our goal is to help you through whatever your journey is in the spine world and get you through it safely. So when you get a chance later, I do have some flyers. We have a dinner seminar set up on June 14th that's sort of directed more towards patients. We'll have physical therapy, we'll have pain management, we'll have a surgeon, I think probably me actually, speak at this. And we'll have dinner, and we'll have a little Q&A afterwards. So hopefully it'll be a little fun, but thank you again very much everybody for your time.
Thank you, Dr. Jin.
Any questions?
Do you
Yeah.
do any artificial disc?
Yeah. So artificial discs, cervical artificial discs. It's interesting because the lumbar showed some promise for several years, and then I think now is really only done exclusively in Europe because I think the outcomes aren't great. Cervical disc arthroplasty or cervical disc replacement, and for certain patients, I think is very helpful. Certainly to help to preserve motion, since you do lose about 10% per level that you do a cervical fusion. So yes, short answer is yes, we do that. Anything else?
Okay, I'd like to invite up Dr. Politi. I'd also like to recognize Justin Schwartz, Lou Donacio. They are the owners of AFC Urgent Care Centers that started in East Meadow. Their second location was here in West Islip. They're up in Ronkonkoma. They just opened up a center in Patchogue, and we thank them for really serving the town of Islip and just being an integral part of our community. Thank you. Dr. Politi.
Well, thank you all for attending. Thank you, President of the West Islip Chamber of Commerce for hosting this event, and Supervisor Angie Carpenter for her support of healthcare here in Long Island to make sure that our residents get the finest in healthcare available for all of us. I'd also like to thank the 2 other presenters with me. I'm honored to be sharing this event with you. 2 of the highest categories of physicians that you might ever need, both neurosurgeons and trauma surgeons. Those are the 2 that you wish you never have to encounter, but knowing that they're here in 2 really fine, prestigious university hospitals in this community really should be amazing. I was saying to them, I sometimes ride a Harley-Davidson motorcycle and take a ride down by the Ocean Parkway, and God forbid anything ever happens to me, knowing that you have this level of care here really is good to know, and something good to have. So I'm Dr. Vic Politi. I'm from American Family Clinic. That's our facility, AFC. I'm an ER doc. I've been an emergency room doc for 35 years. Both in New York City and here in Long Island. Matter of fact, I did a stint at Good Sam as an ER doc for a while before going to National University Medical Center and several other hospitals out here as well. I'm with the AFC as their medical director. AFC is a urgent care center, and no one really knew too much about them before COVID. It was these urgent care centers were dotted around New York and Long Island. And people would go there, for earaches and sore throats and minor injuries and things like that. And then COVID hit, and we realized that no one really wanted to go to the hospital. And we realized that if you did go to the hospital, you had a high risk of picking up some sort of contagion, possibly COVID itself, in the waiting room. And even with the masks and all the precautions that hospitals had taken, you really felt insecure going into those facilities. Urgent cares, we put in a lot of precautions to prevent transmission of disease. A lot of times we gave people appointments to show up so that we didn't have crowds. We would only allow so many people into the facility at a time, maintaining social distancing, and we were able to provide the highest level of care. What we say is know before you go. What options should you know to make the appropriate choice for the type or level of care that you might need? What's the best decision for you and your family, and how that decision affects the appropriate level of care your family receives? And of course, down at the bottom, we don't really think of this that often when we really do need help. We want that help, but cost is always a factor in this as well. So you have to understand what your options are when you want to go to an emergency department or when you want to go to an urgent care, and what is available. So there's different options: primary care, urgent care, emergency department. We all have hopefully primary care physicians that we see for everyday care. But you know, lately it's been very difficult to get appointments. I know it sometimes takes weeks, if not months, to schedule an appointment with your physician for routine care. Maybe blood pressure, or check your A1C for your diabetes, or your prothrombin time, or your partial thromboblast time for your warfarin, or your Coumadin blood thinners, things along those lines. Or you can't get your physician and need a refill on the prescription. And so primary care, although as important as it is, and I initially did my primary internal medicine residency in Princeton in New Jersey, so I'm very familiar with the primary care and the internal medicine field and how we have our relationship with our patients, but sometimes it's just not possible to get in to see your primary care physicians, and we fall into that void where we are available, 7 days a week with a practitioner, a physician that is available to help you with that. The emergency room is there, and there's no doubt. We heard from the trauma center, we heard from the neurosurgeons and the stroke centers, and that, God forbid, we should feel the signs and symptoms of a heart attack, that chest pain, that shortness of breath, the nausea, vomiting, the sweating, the diaphoresis, the palpitations. You don't want to go to your primary care. You don't want to go to urgent care. You want to go to the emergency room. You need an ER doc to take some blood, to check your troponins, to get that EKG, and to treat you immediately with thrombolytics or get you up to the cath lab, which both, and you're so lucky, both Good Sam and Southshire has, both of those have cath labs. A really excellent cardiologists in both of them, actually. So you have that. So you don't want to go to the urgent care for that. You're having a stroke, you can't move your arm, you're slurring your speech, you're losing consciousness. Again, not the place for urgent care, but the place for an emergency department. That said, anything that is less than that, anything that basically you need for a routine checkup, physical exams, sports exams, work exams, college exams, they're available. You walk in, make your appointment, just walk right in. We'll take you right in the back, we'll get all the things you need. Flu shots, vaccines, say you're traveling, we have vaccines available, flu shots and other types. If you're 50 years old or older, you need the varicella injection to prevent shingles, varicella zoster, chickenpox. We have all those vaccines available. Chronic conditions, blood pressure, diabetes, cholesterol. Again, you should have primary care physicians, but we are part of that. We're part of that continuum of care. I'm board certified internal medicine. I treat diabetes, I treat hypertension. These are the bread and butter of internists, the bread and butter of primary care physicians. We can manage your hypertension, your diabetes with your primary care physician, draw the blood tests that are needed, or basically examine you in that meantime. And we also can refer you to a specialist, someone that's coming in when you need that dermatologist or you need that orthopedic surgeon. We do have a list of referrals that we can get to expedite you to get in to see certain types of specialists when you need them and as quickly as possible. Again, appointment times are delayed lately, primary care, very difficult appointments. We're available for you to help. We're after hours. Urgent medication refills. Sometimes you'll see patients traveling in from other parts of the country. They lost their medication, they need a refill, they didn't bring enough. They can come see us and we can examine them and provide that level of care. Infections, any types of cuts requiring stitches. We have sutures, we have staples, we have Dermabond that helps, like the glue that we use to fix small lacerations. All those, any type of everyday treatment for those infections, antibiotics that we can prescribe for you as well. allergic reactions, bee stings, things along those lines, we could provide care for that. Strains, sprains. Most places have x-rays. We're able to provide an x-ray for you if you have some sort of injury that needs to be filmed. Most of them do have x-rays available. If not, multiple sprains and strains, we could treat them, we could splint them, we could ace bandage them, and we have prescriptions for medications that we can provide you as well. Just to recap a little thing that I said about the emergency department, things that you're concerned about: heart attack, stroke, seizures, loss of consciousness, some overdoses or poisoning. The hospitals are set up for those type of events. They have the resources, they have the training, they have the equipment, and most importantly, they can admit you to the hospital for evaluation for those things. So I know Roxanne loves these slides, so I put them on. Difference between stepped on a bee or stepping on a beehive. Right? You have to know the difference, right? So if you step on a bee, it's a bite. We can take care of it. We come on in, we put some ice on it, we clean it up, we give you a tetanus shot. Sorry?
But if you step on a beehive.
If you step on a beehive, I don't know. I mean, that may be just a little too much if you're really having those reactions. And again, you can have reactions from multiple shots or an anaphylaxis reaction, where a person's really swollen, they have difficulty breathing. Really need to be in an emergency department where you need that epinephrine injection and things along those lines. We do have medication for that, but you really should take that level of beehive sting to the emergency department to be treated. And with us, no appointments necessary. Very, very short wait times. We have practitioners available. We have a system where we want to get you out of that waiting room really quick. You go to see the registrar, she takes some information, we move you into a room, someone comes in, gets your history, physical, maybe draws some blood, does the injections, then you move out, then I walk in, the doctor, and I come in and examine you, do what needs to be done. So we keep you moving so that we don't really, you're not sitting in one place too long. We're moving to see you, and we're trying to move you through as quickly as possible. Like I said, most places are x-ray, we draw blood, we have labs, we can draw whatever your physician needs to have drawn for you. If you need certain types of blood tests, we can draw that and send it out to our lab as well. Again, cost, we're not concerned cost-wise when you're really sick, but in general, yes. I mean, we're all on fixed budgets. You're getting your Medicare coverage with that. We're not sure where that's going, what's happening with some of the city workers with the Advantage Care and things. So there's a question of cost. So you need to realize that when you come to emergency department, it's a huge expense, right? It's got to support the hospital. It's got to support the doctors, the nurses, the respiratory therapists, just about everyone that's taking care of you. So there's a built-in cost that's associated with that. In an urgent care setting for a minor injury, for a sprain, a strain, a cut, a laceration, we're minimal. We are a doctor, we're a nurse, we're a PA, we're a nurse practitioner. We're able to move quickly and get you through at a minimum of the cost. So ER skills without the ER bills. We also have other types of care available, ancillary cares. For DOT, we do that to the Department of Transportation. All your truck drivers, your bus drivers, your school bus drivers, they need to go to have special physical examinations. So we're all DOT certified by the Federal Motor Carrier Safety Administration. So we could do these special physical exams for your DOT. The guys that drive the fire trucks, I think they're exempt, but some of the guys that drive buses need to have special DOT certifications. Immigration physicals, no-fault workers, workers' comp. We also do, which is really amazing, and which I'm really glad we do because it really makes a difference in people's lives, allergy testing. So all of our sites have full panels where we can take these allergy samples, allergy tests, to see if you have a reaction to a specific type of allergen. So this type of year, your flus, your colds, your coughs, your sneezes, your sore throats, your rashes, your itches, they may all be related to allergies. And you can come to us, we can test you in AFC Urgent Care, test you, find out what you're allergic to, and treat you, give you specific monoleuclase treatment, leukotriene inhibitors, medications that we could prescribe to you to prevent you from having a miserable spring, from preventing you from having nights where it's hot out, but you got to keep the windows closed because you can't be breathing all that pollen in and having that reaction and wheezing all night and coughing. We could determine what that allergen is and treat you appropriately for it. Again, DMV, vision testing, we have all the available equipment in every one of our sites. So available 24 hours a day, emergency room, yes, great. And you should utilize emergency departments for emergencies. I was an ER doc for many, many years. And so I'm in the ER, I'm working, and we're really saving lives. We're getting people in, heart attacks, gunshots, stab wounds, strokes. We're treating them. The nurses are working their butts off. The EMS guys are coming in. We're doing what we got to do. Sometimes I can't even leave this guy's bedside because I'm changing the IV drips, giving him more nitroglycerin, we're adjusting the ventilators. I'm listening to his heart, making sure the ET tube don't move. You're in the waiting room. You got a cold, you got a flu, you have a fever to 102, you're coughing up green garbage. You need amoxicillin, you need a Zithromax, something. I'll be right there. But you understand, and you've all been there. You've all sat in that waiting room for hours, waiting, because we're not fooling around. We're taking care of sick patients in there, every one of us. So yeah, we are available 24 hours, and we're there for you in the emergency department when you're sick. But realize, when you're there not really sick, we're here. AFC is here, and we're here to help you. So they may have more radiologist specialists, but then if you're going to go to the hospital, be ready for an admission. If you're that sick, they're going to keep you in the hospital. Urgent care, average cost for us less than $200. Average cost way over $1,000 for the emergency departments. Most of us have insurance. Most of it's covered. There are some co-pays in the emergency department, but just understand the cost of health care across the board that it's costing us. And so urgent care, door time, meaning the time you get in, the time you leave, less than 35 minutes when you hit my door. But if you go to the ER, the average waiting time just to be seen is 40 minutes. You're already seen and out the door when you go to urgent care. So we get you, we see you, we treat you, we make the diagnosis, we do a throat swab. We do a full panel, a respiratory panel, where we check you for different types of adenovirus, parvoviruses, rhinoviruses, COVID test. With just one nasal swab, we do a whole series. We're the only urgent care that I know of, and most ERs don't do it, do a full respiratory panel on every patient that comes with these upper respiratory tract infections that indicates that they might have a viral or a bacterial infection, as well as strep testing as well. So we can get that all done while you come in. Urgent care, 50% cases in Suffolk, 17 hospitals. There are 50 urgent care centers in Suffolk and 17 hospitals in Suffolk. So urgent cares are out there. We are available. Again, AFC for comprehensive care for your family, routine care, checkup, physicals, sick viruses, to urgent emergent care. We're here when you need us. Just walk right in. Now, hold on a second. How many see I do this? Take it one more time?
Yep, one more time.
Okay.
FC presents The Time Saver. If you have a minor illness or injury here, don't waste time here, or spend too much money here. Drive past here, and come see us. We'll get you in and out quickly. And back to this. American Family Care.
And that was my wife, by the way. She goes to that. Most times I do the cooking. Yes,
I got a
sir.
question for you.
Yes, sir.
When somebody comes in with a respiratory issue,
Yes.
do you test for Legionella bacteria?
So Legionella bacteria, the way you test for that, believe it or not, is a urine test. It's a direct fluorescent antibody urine test.
Do you test for it?
We could test for it. We could send it out to the lab,
It's not
absolutely.
a normal process.
It's
for
not
it.
a normal process usually, but believe it or not, most of the medication that we give for upper respiratory tract infection, erythromycin, Z-Pak, covers Legionellas. But I remember the days when we couldn't find Legionellas. We weren't sure what it was. And they weren't treating these patients appropriately. And that's why all those Legionnaires died back in Philadelphia. Because it wasn't, we usually for gram-positive and gram-negative staining. So gram-positive bacteria, gram-negative. Legionella was not, it was a spirochete, so it didn't show up positive or negative, so they didn't know what they were treating. They didn't know if it was bacteria, parasite, and so they missed it, and that's why we had a lot of deaths in Philadelphia for Legionella. Today, it's on the top of all of our minds, and when you're coming in, it's either bacterial, viral, even though Legionella is not gram-negative, gram-positive, it's still a bacteria, and we treat for it. We don't specifically test for all bacteria. You come in with pneumonia or cough, we're not drawing bloods and sending it out for blood culture. We treat what's called empirically. So we say, okay, at this age group, for this age population, for these symptoms, you probably have XYZ bacteria or virus, and we'll treat appropriately for it. But yeah, that's a great, direct fluorescent antibodies in the urine is what we look for. If in fact we're really concerned, we would do that, yes.
Okay, thank you.
Yeah, no problem, yes.
In one of the slides, you mentioned about travel.
Yes.
Travel vaccines. I went to Passport Health when I was going abroad or going to Africa, so you would be able to do that.
Well, we could do some of the routine vaccinations, some of the things like, yellow fever that you might get, or malaria Medicaid, that type of stuff. Those are some special types of vaccines. We don't have them on hand. Roxanne, what's the story with, can we order them for particular patients?
So
Is that how we do
yellow
it?
fever, we had to go through a process with the state and apply for it, so we went through the process and we're waiting. Because we do have a lot of people that come in specifically asking for the yellow fever vaccine. So I could be honest with you and tell you it's definitely in the process. But right now, we call New York State so that we can get on the list and make sure that we have it. So we did everything we needed to do, so we're just waiting.
Yeah, some of those special vaccines, you call us, and we'll let you know we have it,
So
yeah.
you have, like if you are traveling, if you want to call us and ask us, do you have this available? We can certainly make things available. So don't ever pass us by. Give us the opportunity to say, okay, you know what, I'm gonna travel, this is what I need, and then we can definitely work with you.
Especially like if you're one of these snowbirds going down to like Boca Raton in the winter, let us know, we can give you a prescription for Briosky or, Mylanta, we got all of that stuff all taken care of. Remember Briosky? Any other questions, guys? Listen, I really appreciate the opportunity to speak to you folks, and thank you very much, and we're here for you. Thank you.